Welcome to our discussion on cpap. We hope to review what it is, what it does, how our equipment might be limiting, and hopefully in a way where we don't lose your attention 2 minutes in. We understand that there are multiple levels of understanding, so I've included a bunch of text and pictures for those of you who don't like to read. This is being brought to you by the Harford County Department of Emergency Services Training Division. We do our best to work for you, so please never hesitate to reach out with suggestions, requests, and edits so that we can bring you the best, up-to-date, and most relevant content. Understand that a lot of time and research goes into these trainings, but we can't do it without you helping us start with a question worth answering. We are happy to leave our contact information at the end. Okay, quick housekeeping item. We are not paid to endorse any specific brand or product. I wouldn't complain if they did, but they don't. Always consult your protocols and follow the advice of your medical director. Device performance depends on setup, supply, and patient factors. Always operate within your scope of practice, licensing requirements, and documentation standards. Okay, so picture this. You are called to a respiratory distress patient. On arrival, the patient appears to be in mild respiratory distress with a pulse ox at 86% en room air. It doesn't look like they are having a crazy work of breathing, so you put them on a nasal cannula. And in short time, the pulse ox is high 90s. They have a history of COPD, CHF, and the whole alphabet soup of long-term problems. In your ambulance on assessment, you notice that they're getting tired, less focused. Their lungs sound tight, maybe diminished, maybe they're not moving much air. But they're definitely not wet sounding, so you start a duo-neb. And again, with the nebulizer, they appear completely content on the oxygen. Now someone decides to place your patient on capnography, and it reads high, in excess of 70, and you think, this doesn't seem right. Who knows? Maybe they're acidotic because they have a UTI, or maybe they have some sort of sepsis situation brewing. They don't have a fever, but infection could explain the confusion, the lethargy, and maybe the high capnography, but she seems otherwise content. Now, I know that I've had patients like this and didn't know what to do beyond just what we're talking about. Have you? Now, we're told the number one reason for altered mental status in the elderly is infection, like a UTI. But is it possible that there's another reason? What if you trust your monitor and they are indeed hypercapnic? CO2 in the high amounts would cause you to get drowsy, and given enough time, they may go unconscious and maybe even stop breathing altogether. Now, some of you might be thinking, bicarb? Some more oxygen? Maybe start breathing with a BVM. But they are breathing just fine at the moment. To tell you the truth, for as long as I've been in EMS, I've never been formally taught that there are two types of respiratory failure. It gets presented like that in medical physiology and critical care textbooks, and to be honest, I'm doing initial education for a college program right now, and I don't think I've ever heard it classified this way in that material either. The paramedic textbooks translates the physiology into practical assessment cues and treatments rather than formal gas exchange classification schemes. It does cover respiratory basics like pathophysiology factors like VQ mismatch, hypoxia, hypoventilation, hyperventilation, minute volumes, and assessing adequate versus inadequate breathing. So is there more to this? Before we talk devices or strategies, we need to lock in a few definitions. This way, we're speaking the same language. Firstly, ventilation and respiration are not the same thing. Ventilation is moving air in and out of the lungs. Think airflow. Air goes in, air goes out. If ventilation fails, often CO2 rises first. Respiration is the gas exchange and oxygen use. This is on the cellular level. Think oxygen gets to the blood, the cells use it, and then CO2 comes back. External respiration is the exchange at the alveoli, while internal respiration is the exchange at the tissue level. You can ventilate someone without oxygenating them effectively, like in severe pneumonia or pulmonary edema. And you can oxygenate and ventilate poorly, like when you have a collapsed lung from atelectasis. Next, hyperventilation and tachypnea get mixed up all the time.
Tachypnea is fast respiratory rate, increased breaths per minute. It only tells you that the rate is fast. But for example, anxiety, breathing really fast but shallow. Hyperventilation is too much ventilation for the body's CO2 production, so CO2 levels drop. Hyperventilation is about CO2, specifically blowing off too much CO2. You can be tachypnic without hyperventilating if the breaths are shallow and ineffective. So, tachypnea means fast breathing. Hyperventilation means too much volume, meaning low CO2. Next, we also have tidal volume. Tidal volume is the amount of air moved with each breath, usually expressed in milliliters. It's controlled ventilation. We target milliliters per kilogram. If the rate is how often, the tidal volume is how much per breath. Now the minute volume, or the minute ventilation, that is how much air you move in 1 minute. So the minute volume is the respiratory rate times the tidal volume. So if you increase your minute ventilation by increasing the rate and increasing the tidal volume, or one or the other. So for instance, if someone is breathing 10 times a minute with a tidal volume of 500 milliliters, that's 5 liters per minute. Now PEEP. PEEP is the positive end expiratory pressure. Now this one's important. PEEP is the pressure left in the lungs at the end of exhalation. It's what keeps the alveoli open, prevents them from collapsing. This is what improves oxygenation by recruiting more alveoli and increasing the functional residual capacity. PEEP is what mainly helps oxygen, not CO2 removal. But too much PEEP can reduce venous return and drop the blood pressure. It can increase the risk of barotrauma and volutrauma. So, to quickly wrap it up, ventilation is air movement and is tied to CO2. Respiration is the gas exchange and oxygen delivery. Tachypnea is a fast rate. Hyperventilation is low CO2 from excessive ventilation. Tidal volume is per breath. Minute volume is per minute. And PEEP is what prevents alveoli from collapsing at the end of exhalation.
Okay, a few more definitions. FRC, or functional residual capacity. This is one concept that I know we didn't talk about in paramedic school. If you're in critical care, maybe, but simply put, remember when you do a spirometry test and you exhale and then they tell you to keep pushing more air out until you feel like you can't, this is your FRC at work. While you exhale, you are about to take another breath and your FRC is still exchanging CO2 and providing O2 between breaths like a buffer. The FiO2 is the fraction of inspired oxygen. Regardless of how much a volume of air you breathe in, room air is still 21%. And a non-rebreather, it's not actually 100% FiO2 because you can generally breathe around the mask. So even a BVM oftentimes is not 100% FiO2 because you have the ability to entrain air from the outside in addition to the 15 liters we have it attached to. The PIP, or the peak inspiratory pressure, this is a concept that we usually only talk about when we're talking about a BVM or on a ventilator. It is the max pressure that you would need in order to properly inflate the lungs. We'll demonstrate that in a minute with a manometer. And then finally, flow. Now this is not to be confused with the O2 setting on your tank. This is how much flow of air you would need to take a breath. It's like if you were underwater, would you be breathing like you're trying to get air through a straw, or would you prefer a traditional snorkel? A peak inspiratory flow could be 20 to 30 liters per minute for an average adult when calm, 40 to 60 when they're in mild distress, and in excess of 100 to 150 when they're gasping for air. More on this later. To help visualize what PEEP is doing using a BVM and our test lung, my goal here is not to exceed a peak inspiratory pressure of 25, say 20 or 25. It's nice having a BVM with a manometer built in. Notice when I add the PEEP valve to the BVM and it's only set to 5, there's an increase in the functional residual capacity. This recruits alveoli for the next breath. This also allows for CO2 to exchange between breaths. And now I'll up the PEEP to 10. Trying to keep out of the yellow, notice how little air is allowed in and out. This means that not all patients will benefit from more PEEP. At some point, patients' compliance will decrease, so every patient is different. There's no set rule or number. For you respiratory nerds, this is relating to Fick's law of diffusion, which states that the rate of gas transfer is directly proportional to the surface area and inversely proportional to the membrane's thickness. When alveoli stretch, there is more surface area for exchange, and when the walls of the alveoli become thinner and the surface area increases, diffusion rates drastically improve. So, what does this patient need? This patient is suffering from atelectasis, not to be confused with a pneumothorax. When the alveoli are collapsed, patients with emphysema and COPD are at significant risk of this, whether sedentary, post-surgical, prolonged bed rest, neuromuscular weakness. Remember, your FRC is the air that is still in your lungs at the end of exhalation. This is where CO2 gets offloaded. She needs some more pressure support to keep those lungs inflated between breathing. It's not oxygen that will fix this. Once at the hospital, they will likely put her on CPAP or more likely BiPAP to increase the surface area of her lungs. This will allow for gas exchange. If not corrected, as the CO2 levels increase, she would likely lose consciousness and ultimately stop breathing altogether. She doesn't necessarily need a high FiO2, room air might even be plenty. But honestly, take a minute to think about past patients you've had that you've treated that might fit this scenario. I know I've had quite a few, but we just didn't know. Let's change gears for the people who only look at the pictures. Let's start with the basic test of your knowledge with some easy questions. 1. Do rabbits eat carrots? 2. Do you think that CPAP uses force and positive pressure to push fluid out of the lungs? And 3. If Rob and I were called a pair of Nimrods, should we be offended? So let's start with number 1. In short, no. Rabbits can eat carrots. Nothing's stopping them from eating plastic either. But the truth is, carrots are very disruptive to rabbits' delicate balance in their gut, and even can cause some painful gas and digestive issue. Not to mention it's way too high in sugar for them. But then why do we always picture rabbits with carrots? Well, in the 1934 movie It Happened One Night, Clark Gable was pictured eating a carrot. When Bugs Bunny was seen mimicking this, the 1930s audience immediately would recognize this as a parody, almost like an OG meme. However, as time went on, the younger crowds just saw rabbits and carrots as something that went hand in hand. This was passed down and continued to even today. Toys, stuffed animals, Easter candy, AI images, everything pictures rabbits and carrots. I seriously doubt we did this to keep it going for some sort of rabbit crowd control, but we really just didn't know any better. So what are your thoughts about CPAP pushing fluid out of the lungs? Just like our misunderstanding of rabbits and carrots, we likely made that assumption early on. The truth is, even today, the vast majority of providers still say this. I'm not exactly sure why that could be. Maybe it has something to do with publications like GEMS, when a physician describes how this new field device would generate pressures to move fluid out of the lungs. Or maybe it's because we were given these devices with little to no training, and when listening after application, the triple thick milkshake sound they had just started to disappear, and we thought, hey, it worked. Let's give some more Lasix just to be sure. In acute pulmonary edema, the continuous pressure of CPAP worked to prevent additional leakage of fluid from the pulmonary vessels into the airways by creating a positive pressure gradient. And it's often theorized, not proven, that CPAP may force fluid congesting in the lower airways back into the pulmonary blood vessels. So yeah, it really is still a myth. What do we agree it does? It splints alveoli, it increases functional residual capacity, and it decreases shunt, which assists with oxygenation. allows for the active sodium transport system to move fluids into the lymphatic system, and okay, enough with the big words. Maybe I can explain in a picture. Who picked these pictures? Picture this. The alveoli clear fluid by pulling salt first, then water follows. Type 2 alveolar cells have a front door sodium channel that pulls sodium out of the fluid into the air sac in the cell. On the back side, a pump uses energy to push the sodium into the tissue and then the bloodstream, and this creates an osmotic suction, so water then follows the sodium out of the alveolus into the interstitium and then into the capillaries. So simply put, move sodium out and water follows. Air sacs dry out, oxygenation improves. There are way more boring details, but for now, let's just agree that this is more than just getting rid of some fluid than just some sort of magical push. When talking about CHF patients, we seem to really focus on the breathing trouble and the fluid in the lungs, but we also forget that this is a heart problem. I mean, it is part of the name, congestive heart failure. So for those of you that didn't pay attention in this part of your class, our goal here is to deal with the heart failure, which then fixes our breathing issue and not the other way around. For you firefighter types, it's like if you had a trapped firefighter, do we rescue them or do we just put out the fire? If we put out the fire, then we can take our times getting pictures of the new guy with his foot stuck in the floor rather than rescuing him while the fire is all around you. For many of you old people, seasoned medics, you're among friends. We can admit that we were never taught this. CPAP was not covered in our initial education. They just gave us CPAP devices and wished us the best of luck. So this might be the first time that you actually hear that, and that's okay. And I'll say it again, congestive heart failure is a heart problem. It's not a lung problem. It's lung symptoms. Let's review so we're on the same page. So imagine you have two pools of water and two pumps in between them. In this situation, you would need both pumps to be operating at the exact same volume per minute to keep up at this level. Now notice I said volume, not speed. If one pump starts to slow down, the result will be overflowing on the upstream pool when it backs up. Eventually, it all needs to go somewhere. But if those pools had lids on them, what do you expect would happen? Similarly, we have the same problem in the body. Here we have the left and right heart, which act as two separate pumps. Like the pool example, they are connected via large pipes, and they operate on a closed loop that really can't overflow. It's got to go somewhere. So I'll attempt to illustrate this by separating the heart into two pumps, left and right side. Now bear with me here, I'm a paramedic, not an artist. In between the right and the left side of the heart will be the lungs, and at the base levels you'll have the alveoli. This is where red blood cells and hemoglobin is brought down to single file lines across the membranes. The blood then returns to the left atrium, then the ventricles for distribution of oxygen throughout the body. In between the left ventricles, where the blood flows out of the aorta and returns on the right side, there's the rest of the body. When there is right-sided failure, the result of that backup is in the form of edema. But it won't just present as pedal edema, because you have the rest of the organs in the GI tract and the liver that drains into the body. And when that backup compounds, you'll get fluid showing up in the belly in the form of ascites. Often is why people don't want to lay flat. Remember, these are the patients that you'll have sleeping with multiple pillows, or they may say that they need to stay upright in a recliner or something like that overnight. Now when you have left-sided failure, you have the backup of blood not effectively leaving the lungs, but also an influx of blood from the still pumping right side. This causes an increase in pulmonary pressure, or otherwise known as pulmonary wedge pressure. We call this pulmonary hypertension. It eventually results in leaking in the thinnest parts of the system, i.e. the alveoli. When air still comes in and out, it gets frothy, and we see it as pink frothy sputum. This is the classic slide we've been seeing forever. Both right-sided heart failure and cor pulmonale will display similar symptoms. Cor pulmonale, or pulmonary heart, is defined as an altered structure or function of the right ventricles due to a pulmonary disorder of the respiratory system, like COPD or pulmonary fibrosis. This is why you often see COPD and CHF hand in hand. Now, right-sided failure can also result from left-sided heart failure, valvular disease, or cardiomyopathy. Treatment here would focus on the use of diuretics, sodium restriction, and fluid restriction if early or chronic. However, if this is severe or sudden onset, your pressure may appear soft. We would use fluids carefully and consider pressors like epi. When we see this, we need to consider not just CHF, but right-sided failure. Remember, CPAP would be lowering a blood pressure, because it lowers preload in the failing right side. We definitely need to consider what caused this. Was it the left side causing right-sided strain? Is this a STEMI? If so, do a right-sided EKG. If the onset is very sudden, maybe consider a massive PE. In left-sided heart failure, I've been often told that you have a slow onset, slow treatment timelines. But these patients are the ones who will earn at least an equal amount of time in the ICU as their onset. But the quick onset means the need for aggressive treatment from us in the field. This is your SCAPE patient, or sympathetic crashing acute pulmonary edema. It is a life-threatening and often an extreme form of heart failure driven by a severe, rapid onset of hypertension and a sympathetic surge. This causes immediate fluid shift into the lungs rather than a true volume overload. Remember, the right side of the heart pumps blood to the lungs, and the left side is responsible for moving blood away from the lungs and out to the body. Now, when the left ventricle is failing, it can't effectively move blood forward. Blood backs up into the pulmonary circulation. Meanwhile, the right ventricle is still pumping blood into the lungs. Now, the alveoli are exposed to increased pressure from two directions: backup pressure from the failing left side and continued forward flow from the right side. This increased hydrostatic pressure forces fluid out of the pulmonary capillaries and into the alveoli. As the fluid fills the alveolar space, we will hear rales. The patient will start to feel air hungry. Oxygen diffusion becomes impaired. Carbon dioxide will diffuse more easily through the fluid than oxygen, so oxygen will fail first. This is type 1 respiratory failure, failure to oxygenate. Now, how CPAP helps here is that it improves oxygenation in two major ways. First, it recruits and re-expands the alveoli, this increasing available surface area for gas exchange. It also increases intrathoracic pressure, which compresses the vena cava, the superior and inferior vena cava, because of the crowding in the chest with the larger lungs. This also reduces venous return to the right side of the heart. This reduction in the venous return is what we mean by decreasing preload. So less blood returning to the right side of the heart means less blood being pumped to the lungs, a lower pulmonary capillary pressure, and reduced ongoing fluid leakage. So CPAP helps by both improving oxygen exchange and by reducing pulmonary congestion. Remember, the priority here for the severe pulmonary edema patient is to reduce the preload and help with oxygenation using CPAP. In Maryland, we have nitroglycerin to help aid in reducing preload. However, this is until we get CPAP on. This means we really should be bringing CPAP to the patient, not bringing patients to the CPAP. The Maryland protocols do not give a lot of guidance for where you should start your PEEP settings. Remember, however, that this can be a quite claustrophobic feeling. I've had countless students and providers try on a CPAP device only to have a completely changed outlook on their patient's experience. I recommend placing a patient on a PEEP of 0 or as low as possible to let the patient get a chance to acclimate to the mask being on them like a face sucker from Aliens. Then gradually increase them to a PEEP of 5. Patients such as a COPD or asthma patients, they need a lower PEEP to prevent air trapping or a worsening of their auto PEEP. Severe ARDS patients, especially from what we saw during COVID, they would need like an initial PEEP in the 10 to 15 range. This is to balance between too much PEEP and if you have too little PEEP, you might have a terrible compliance. Unfortunately, in the field, we just don't have the fancy equipment to measure this, so we need to make gradual changes and then assess. There's definitely a balance between too much PEEP and having terrible compliance. Unfortunately, in the field, we just don't have the fancy equipment to measure this, so we need to make gradual changes and then assess. Keep an eye on that blood pressure. Yes, higher PEEPs will stretch the alveoli thinner. It will help with oxygenation, but it's like blowing a balloon up. I really dislike that feeling you get when you don't actually know how large it's capable of getting right before it pops. It is absolutely true that CPAP has reduced the need for intubations in the field. Nurses hated us for all the nasal tubes we used to bring them before we got CPAP. CPAP requires active participation from your patient, so if they begin to head bob or quit mentating properly, you need to switch gears and quickly. Similarly, if you look at your patient and the mask is filled with a Chipotle burrito, they are no longer a candidate. If your patient is fighting you, the answer is not to simply fight them. How many times have we seen providers hold it to their face while saying, "Oh, no, keep it on, it's forcing oxygen," while the patient is actually saying, no, really, I can't breathe. This does require some coaching, some reassuring, and also just possibly listening to the patient, because unfortunately, they may not be getting enough flow and they're actually suffocating. One issue we found was with the port O2 vent. You know, what we call the yellow box CPAP. This one creates a max flow of 100 liters per minute. It does claim to have an anti-asphyxiation valve once the unit is out of gas, but it otherwise does not seem to have a way to entrain or let in outside air. I learned from experience that if your patient's flow requirement is higher, for instance, someone who is tachypnic or has a high tidal volume, this will cause a patient to actually suffocate. You will know because when they take a breath, it will go into a negative reading on the dial. Oh, and your patient will be fighting with you. He's probably saying, I can't breathe. You might not want to fight these people. Alternatively, we've been carrying the Pulmodine O2 Max system, but it was pointed out from the field that these are designed to be hooked to the high pressure port. They use a Venturi system to provide a flow up to 140 liters per minute, and it does come with an anti-asphyxiation valve. However, it has a fixed FiO2 of 30%. We did look into the fix of getting a trio adapter. However, this would mean that at 90% it would likely empty a bottle in under 4 minutes. A Jumbo D cylinder would really only last for 6 minutes, and that is assuming, of course, that you had a full one to begin with. We all know how Murphy's Law would apply here. So remember, coach your patients with a lower PEEP setting before dialing up. Coach them rather than use brute force. Remember that you need to adjust your treatment to match your patient. If you need a higher FiO2, consider maybe adding something inline or a nasal cannula. If they need a higher PEEP, adjust a little at a time and constantly evaluate how a patient is tolerating it. Let's all be honest, how many times have we heard this said? Or even said it ourselves? Or heard a firefighter say it and thought, it's not even worth correcting. I think we're all in this boat together. Now again, Fick's law of diffusion describes how fast a gas like O2 or CO2 can move across a membrane, like the alveolar capillary membrane. Simply put, the more surface area that exists, the more O2 and CO2 exchange that can happen. The thinner the membrane, the easier the gas can cross. The less resistance there is, the larger the pressure difference, the easier it is for us to cross from a high to a low concentration. So CPAP doesn't push oxygen, it holds the alveoli open by splinting them. Yes, with oxygen. Honestly, most of the CPAP devices out there are really just PEEP devices. They provide PEEP by putting a valve held down with a spring over the exhalation port. It's like someone putting a pillow over my face if I'm snoring. It creates pressure in the alveoli when I'm exhaling. Other types of CPAP pressure is like driving in a sports car at a very fast rate of speed with your head out the window. It's not making you take a breath, but it is keeping the alveoli open.
Hey, what do you recommend for CPAP?
Oh, hey, I'm glad you asked. We spent quite a while researching devices and we landed on Mercury Medical's FlowSafe 2. This device is flow powered, Venturi-like driven, creates a pressure through the entire breath cycle, has an actual air entrainment and anti-asphyxiation valve, and an overpressure pop-off safety. It's not run by a turbine or an electric fan, and is able to give off high FiO2 and flow to cover a higher spread of patients. PEEP is determined by the flow from your low pressure O2 regulator, and you can verify it using a built-in manometer. This also allows you to verify that you have a good seal. It uses a low pressure from any O2 regulator rather than relying on the high pressure ports and modifications. It provides peak flows well over 100 for those patients that are air hungry and is completely disposable. The best part is it's simple. Now there are limitations, of course. The max PEEP on this device is 13 as opposed to 15 on some others. They do admit that similarly to the Pulmodine device, it can entrain more outside air when you have higher tidal volumes. So we need to be aware that as you increase PEEP and you realize that your FiO2 doesn't seem to be high enough, you can supplement this by a nasal cannula or by putting oxygen tubing right to the mask. This feature was important to the European EMS agencies. This might require a second oxygen source, but by the time you realize you need this, we should hopefully be at the ambulance. This, of course, is not the end-all be-all device. We are always welcoming of suggestions. This device does have some fancy bits, though. They make a version of this where there's a built-in nebulizer so that you only need one oxygen source. But where this product really shines is the FlowSafe 2 Plus. This is a bi-level version where you can start the patient on CPAP and then switch them to bi-level with a flip of a switch. This means easier breathing experience for those tired type 2 patients without the need for expensive mechanical ventilators. This is game-changing for respiratory care in the pre-hospital world, and I just wish that I had found this sooner. A little more on this later. Okay, for those of you who didn't pay attention at all, we are at the end, so listen up. The biggest takeaway here is that CPAP is not just a respiratory device, and it's not just a device for fluid in the lungs. It is a heart machine, and it can significantly change your patient's hemodynamic status. We focus so much on just deciding if the patient should get a duoneb or nitro without thinking of the whole picture. We don't generally identify patients in respiratory failure as one of two categories, and we really haven't considered hypercapnia as hypoventilation or fatigue. We should coach these patients rather than suffocate them and not expect high pressures will cure everything. We are smarter than this, and I hope that this gave some confidence and some reassurance that we are capable. Oh, and I almost forgot. Someone called me a Nimrod, and I thought, should I be offended? Originally in the Bible, Nimrod was a powerful king and a legendary hunter. Then came along Bugs Bunny, and using it sarcastically, like, hey, nice work, Nimrod, the meaning basically face planted into a modern slang. So if my colleague calls me a Nimrod, I don't feel personally attacked, but then again, that's not the point. The point is this. In EMS, we don't hunt rabbits, we hunt bad information. We track down the myths, we follow the evidence, because patients deserve facts, not folklore. So congratulations, you are not just CPAP users anymore, you're more like CPAP Nimrods. For more information, feel free to contact us at any time.